Good afternoon, my dear friends. After a long time, we are meeting once again. So, on behalf of IIMS and Tamil Nadu, I am Dr. Sabrinath Ravichandar, consultant pulmonologist. Fine. So, today we will discuss one case scenario, and based on that, I will be giving you some ideas what could be the questions asked from that case. So, let us start our case. Is a 30-year-old female, so who is an homemaker, belonging to a low socioeconomic class, coming from an North Chennai, from an housing board area, with complaints of cough for the past 1 month, and there is also fever for the past 1 month. Patient is also having slight breathlessness for the past 1 week. History of presenting illness: patient was having cough which was productive in nature, and it is there for the past 1 month. Patient is producing yellow color, mucopurulent in consistency, not mixed with any blood, and patient is also having breathlessness for the past 1 week, which was insidious in onset and gradually progressive, not associated with any orthopnea or paroxysmal nocturnal dyspnea. At the same time, patient is also having a fever, especially more in the time of evening she is able to feel. She is having a loss of weight and also a loss of appetite, and there is no any other constitutional symptoms. Past history: she is a known case of diabetic, type 2 diabetes. She is on regular therapy, but her sugar levels are not very well controlled, and no any other significant past history. Personal history is not significant in her case. Family history is not significant. Contact history: her neighbor was having tuberculosis nearly 2-3 months back, and she is also on anti-tuberculosis therapy. So on general examination, patient was conscious, oriented to time, place and person. Then she was ill-built and not well nourished. No pallor, no cyanosis, no icterus, no pedal edema, no generalized lymphadenopathy, and clubbing grade 1 was present. Vitals: everything seems to be normal. Then on examination, on patient inspection, slightly movements were found to be reduced on the right sided, mainly in the infraaxillary, infrascapular regions. On palpation, all the trachea is in midline, even the apex beat was in the normal 5th intercostal space, half inch medial to the midclavicular line confirmed. But on palpation, one finding was that the movements are decreased in the right sided infraaxillary, infrascapular regions. The vocal fermitus is reduced in the right infraaxillary, infrascapular regions. In percussion, everywhere the normal resonant node was present, but there was a dull percussion node present in the right infraaxillary and infrascapular regions. On auscultation, normal vesicular breath sounds were heard all over the lung except in the right infraaxillary, infrascapular regions. You were able to hear decreased breath sounds, and same time vocal resonance was found to be decreased in this right infraaxillary, infrascapular regions. Examination of other systems: cardiovascular system, S1, S2 heard, no murmur, no gallop, no rub. Per abdomen, soft, no any organomegaly, and in CNS, no focal neurological deficit seen. So this is the entire summary of my case. So at this point, the examiner will ask you, "Sir, can you just summarize your case?" Then your summary can be like this. So my case is a 30-year-old female who belongs to a low socioeconomic class, who is a known case of uncontrolled diabetes, who is having a contact history of tuberculosis, presenting with complaints of evening rise of temperature, loss of weight, loss of appetite, cough with expectoration for nearly 2 months, and patient is also having breathlessness for the past 1 week. Okay. On examination, grade 1 clubbing is present, movements are reduced in right infraaxillary, infrascapular regions, vocal fermitus, vocal resonance is reduced in right infraaxillary, infrascapular regions, breath sounds are reduced in right infraaxillary, infrascapular regions, dull note on percussion on right infraaxillary, infrascapular regions. So what could be your differential diagnosis? In the first introduction class itself, I said your diagnosis must be pointing the pathology, must be pointing the anatomy, must be pointing the etiology. So here, from the way I presented, you people could have easily found where is the anatomy, where is the pathology, where is the etiology. Definitely anatomically, I am damn sure this case should be an pleural effusion. I think most of you will agree with me. But some may argue that, sir, this patient is having a productive cough. Why are you saying it is a pleural effusion? Yes, I am saying pleural effusion is main, but who knows? There may be even a parenchymal lesion, who knows? there may be an underlying parenchymal lesion such as some cavity or some consolidation changes or some tuberculous infiltrates which is producing sputum. So along with that there is a pleural effusion. Are you understanding? So parenchymal along with pleura. So since the parenchymal involvement is there, maybe the patient is producing sputum. Okay. So this is my anatomical diagnosis. Definitely parenchymal involvement will be there either in the forms of infiltrates or some consolidation. Definitely pleural effusion is there. Pleura is involved. No doubt in that. Okay. Why? What are the positive findings on my examination to say pleural effusion is there? Here starts my examination points of questions. What are the points? On inspection, I am feeling an decreased chest movements. On palpation, I am confirming my decreased chest movements. On vocal fermitus, I am asking the patient to say 99, 99. I am able to see an decreased vocal fermitus. Same thing when I am doing with stethoscope, that is called vocal resonance. That is also decreased in that particular area. And same time, I am able to what? In percussion, dull note is there. So that is also showing that the patient is having an effusion, dull note in percussion, and even the breath sounds are decreased. So all these combined together, definitely I can say it is effusion. Please, my dear students, don't get confused that in effusion the trachea will always be shifted to the opposite side. The cardiac impulse, the apical big impulse, apex beat will be shifted to the opposite side. It is not mandatory in all the cases. So what it does, it means trachea is over here, apex beat is over here, right? My case is an right-sided pleural effusion. For this effusion to push the trachea to the opposite side, will a mild effusion push? No, because my patient is having only breath sounds decreased in infraaxillary and infrascapular areas. So what does it mean? Only in infraaxillary, infrascapular areas means the effusion is mild. So a mild effusion never causes shifting of trachea or apex beat. And many times some people do mistake. So the trachea shifted to opposite side, but the apex beat is in the normal position. How is it possible? Which is downmost? Apex beat is over here. Trachea is over here. Water is coming from down to up. So which the water will first push? Water will first push the apex beat to the opposite side. Okay. So if you are saying trachea is pushed to opposite side means it is a massive effusion, my friends. It is a large effusion. If it is a massive effusion, definitely the cardiac apex also should have been shifted to opposite side. Do you agree or not? So please understand these basic points before committing big mistakes in exam. Understood? Okay. So my case is a case of an right-sided pleural effusion. I can say definitely it could be minimal, that is mild to moderate effusions. Mild to moderate effusion, because only the infraaxillary regions and infrascapular regions are involved. Next, etiological diagnosis. What should be the etiology? Patient is of what? Diabetic, that means she is immunocompromised. Patient is having contact history of tuberculosis. Patient is living in country like India. Patient is living in an housing board area where there will be very less space. The space normally 110 square feet is required for 2 people, whereas in housing board area not even 90 square feet will be there for 2 people. So overcrowding is there. She is having a contact history of TB and she is presenting classically with cough with 2 months, loss of weight, loss of appetite, evening rise of temperature. What else could be the cause? What else could be the cause? Definitely, I am damn sure it should be tuberculosis. So I am going to say to my examiner that my case is a case of an right-sided mild to moderate pleural effusion with mostly secondary to tuberculous etiology. So this is what? Anatomical, pathological, etiological diagnosis. Right. After this, now the examiner will go inside some questions. So right now I have given you the entire gist how a pleural effusion case will be there from up to down. Okay, what are the histories, then what will be the relevance of histories, and now the examiner will go to the questions. He can ask questions from anywhere in between. Example, when you are saying his name, age, sex, I think everything we discussed in the last class. Then when you are asking about the symptoms, he can stop you and ask about anything about cough, anything about breathlessness, anything about hemoptysis, especially when there is a hemoptysis case. Patient in TB will have hemoptysis. Questions will go inside that. What are the causes of hemoptysis? Okay, what is the types of hemoptysis? What is classical hemoptysis? What is pseudo hemoptysis? What is spurious hemoptysis? What is endemic hemoptysis? So these are all the questions asked in hemoptysis. Why a patient of hemoptysis will die? What is called as mild, moderate and massive hemoptysis? So everything they will ask. Okay, if there is a hemoptysis, be ready with these answers. Okay, everything is available in my book. All the answers in hemoptysis is available. Okay, next they may ask evening rise. Why there is an evening rise of temperature in tuberculosis? So we know because it is of cortisol levels. Last class we discussed. So they may ask questions regarding that. Loss of weight, loss of appetite. Okay, how will you say whether there is a significant loss of weight? All those three criteria is there. Okay, 15% in the 6 months. The criteria is there now. So we have to say about those criteria. Then past history. Then definitely if there is a history of an diabetes. Okay, then diabetes is an immunocompromised state. So they can go anything about diabetes and ask what are the risk factors if a patient is having an uncontrolled sugar. This female patient is luckily is not a smoker. If suppose it was a male patient is a smoker, they can ask anything about smoking. All the packets, everything, index, everything they can ask. Anything they can ask. History of alcohol if it is there, what is the relevance that with TB? Anything they can ask. Okay, so like this, be ready with the questions which is coming in between. Just you have to develop your knowledge. So only I am saying some basic facts you have to be knowing first. So which was discussed in our first class. That is the introduction part. Now when you are going inside the case, you should be ready to face those questions from the basic facts. Then again when you are coming to the examination, each and everything they can ask you to demonstrate. Okay, show me what is pulses paradoxes. How will you demonstrate clubbing? What is grade 1 clubbing, grade 2 clubbing, grade 3, grade 4? Demonstrate all these clubbings. What are the causes of clubbing? Nearly 10 to 15 questions are there in clubbing. They will ask you. Pallor, icterus, everything. What are the causes of the pallor in respiratory system, icterus in respiratory system? If your patient develops icterus, what will you think of? Anything they can ask. Okay. Then similarly, when you go for the examination, each and every examination, I will try to post some videos how to examine a respiratory case. Okay. Each and every examination, they can ask you question. Okay. Do palpation and show. Check for the chest movements. Look for apical impulse. Look for the trachea. 1 finger, 2 finger, 3 finger techniques of tracheal palpation. Okay, how will you percuss? Please show me tidal percussion. Please show me cardiac percussion. Please show me liver percussion. Drop space percussion. What is drop space? Everything they can ask. Similarly, in auscultation, they can ask anything. Okay, what are the areas of auscultation? What is where are the conditions where the breath zone will be decreased? Because our case breath zone was decreased. So where a breath zone will be decreased? What are the causes of decreased breath zone? What are the causes of absent breath zone? What are the causes of unilateral decreased breath zone? What are the causes of bilaterally decreased breath zone? Bilaterally absent breath zone? Anywhere the question can go. Right? Vocal resonance, you are saying vocal resonance, vocal firmity is decreased. So they can ask a question. What is vocal resonance? What is vocal firmity? Please say. So you should be thorough with the answers. Example, if they ask you, what is vocal resonance? You should be very spontaneous. When a patient is asked to say a monosyllable like 99, the sound which is produced in the vocal cord is transmitted to the chest wall and which is oscillated by a bell of a stethoscope. That is called as what? Vocal resonance. Similarly, vocal firmitas, everything is same. When a patient is asked to repeat a monosyllable like 99, the sound which is produced in the vocal cord is transmitted to the chest wall, which is palpated with an ulnar border of hand. That is called as vocal firmitas. The questions, the answers should be fut, fut, fut. Clubbing. What is clubbing? They will ask you 100 times. Definitely, these are the questions to be asked in undergraduates. Man, what is clubbing? Bulbous enlargement of the distal phalanges, which is due to proliferation of the subarachnoid tissues, characterized by obliteration of the angle between the nail and the nail bed. So you should be very instantaneous in answers, not even having a little flaw. Are you understanding? So in between your entire case, all these questions can be asked from anywhere. And remember, if you are very good in answering these answers, you are 100% pass. No need to even go inside discussion of pleural effusion. If you are just crossing this path so smoothly, 100% pass. Okay? You won't believe, in my post-graduation exam, in MD Pulmonology exam, when I was attending, normally a long case will be 40 minutes. 40 minutes. I was the only South Indian candidate because I was studying in North India. Okay? Rest all three were Gujaratis. All the rest 4-5 people were Gujaratis, and I was the only person who was from Chennai. Okay? I was the first candidate to go in. One external is from Jaipur, one external is from Mumbai, one external is from UP, and one is my internal sitting from Gujarat. Okay, you know the way they ask the questions, they nearly ripped me for 1.5 hours. Nearly 1.5, 40 minutes is the long case. They had been asking me questions for nearly 1.5 hours. Okay, and you know where did we go? My case was a case of a fibrocavitary. We will discuss about it in later classes. Fibrocavitary. You know where I was after 1.5 hours? I was still in the end of auscultation only. So till I was in end of auscultation only, history taking to auscultation, 1.5 hours me alone standing and explaining with the case in front of 4 examiners. All were asking me questions. I was answering to all. At the end of 1.5 hours, they were not able to trap me in even only one question. Then after that, my assistant professor from back said that please stop answering. And then purposely I did 1-2 mistakes, and after that only they left me. So that time I found that they should not answer even too much also. In fact, 1-2 examiners were very happy. They gave me a very good mark. They gave me a gold medal which is hanging in my home. Okay, that all is there. But what I want to say is that flawless answer should be there. I was very keen and I was very sharp to take the question or to take my case presentation in the areas where I was very thorough. If they ask me questions about clubbing, it is like a laddu to me. If they ask questions about inspection, palpation, percussion, it is like having a chicken biryani to me. Because those are the areas where I am really strong. But suppose if I go to some discussion part and get struck in the areas of very dangerous, example, what are the embryologically, which bud it is coming, I know, but I am not very thorough. Are you understanding? If they go to the ancient histories and ask where was the first pleura diagnosed, who was the inventions, I am not very thorough. So I made sure my case is going flawless and correctly in my direction, and the examiners are following along with me, and I was answering. So at the end of 1.5 hours, I stopped answering. I was been given the first mark and a gold medal in my exam. I am not saying it for my proudness. I am just saying for motivating you. Okay, what is the use of that gold medal? Nothing. It's simply hanging only in home. That is different. But I am very much equipped now with pulmonology knowledge. I am loving the subject now because I read it to the core. Now I am able to see my patients in my clinic very nicely. Now I am able to see many cases nicely. I am able to give lot of interviews in televisions, in radios, clarify without any fear, because I know the subject. That is what I want. That is what I want, not the gold medal which is hanging. I hope you people understand. Okay, in the next 10 minutes, I will be discussing with you some of the important questions which they can ask you in pleural effusion. You can make a note. They can ask you about embryology of pleura, where does the pleura develop from. They can ask you what is the normal amount of pleural fluid present in the pleura, that is at 5 to 15 ml. What is the rate of formation of pleural fluid? Okay, 0.6 ml per hour or 0.01 ml per kg per hour. Everything is there. See, this is, I'm just showing you. This is my book. Okay, RS by RS, Respiratory System by Ravichandra Sabrinath. I had discussed all the cases in this with all the answers. Okay, so no need to worry. Your sir is not saying the answer. Everything is there in the book. But the way I am motivating you and sharing my experience is what this video going to say. The way to read pulmonology, the love towards the subject, that you cannot get in my book. I am not able to throw that feelings in my book. I can just throw the facts. Each and every fact, how much difficult I collected, I only know. I am giving you like a laddu to you. You have to just eat it. But please know the subject properly. Love it and then eat it. Otherwise it will get forgotten. Are you understanding? Right. So those questions can be asked. Then they can ask you, what are the different forms of effusion? Transudative and exudative. What are the different mechanisms of formation of pleural fluid? From where the pleural fluid is formed, from where it is absorbed. All these questions they can ask you from the basic part. Then transudative, exudative, definitely please everybody remember about Light's criteria. Each and every student must be thorough with Light's criteria. What is Light's criteria? Definitely this question is going to come to you. So pleural fluid protein divided by serum protein if it is more than 0.5. Pleural fluid LDH divided by serum LDH more than 0.6. Pleural fluid LDH more than 2/3 of the upper limit of the serum LDH. Out of these three, even if any one point is positive, the fluid is exudative. This is the Light's criteria. Please be thorough. Even at night they wake up and say you should be knowing. Apart from this, what you should know. What are the causes of transudative effusion? What are the causes of exudative effusion? what are the causes of right-sided effusion, what are the causes of left-sided effusion. Okay, so they can ask you questions even like this. They say that trachea is shifted to the opposite side in a massive effusion. If the patient is having a moderate or massive effusion but trachea is not shifted, trachea is in center, what are the causes? What are the causes of pleural effusion with central trachea? Very important question. So you have to answer like this: bilateral pleural effusion, minimal pleural effusion, loculated pleural effusion. So these are the answers. Understanding? So similarly, a lot of questions can come. If there is a patient of pleural effusion having clubbing, what will you think of? I will be thinking of empyema. Okay, the effusion will be an empyema causing clubbing, or I will be thinking of an malignant pleural effusion. Malignancy, lung cancer is the cause of an clubbing. So this should be your answer. Understood? Then like this, many basic questions they can ask you. What are the drugs causing pleural effusion? Okay, what are the does radiation causes pleural effusion? Okay, lot of questions. Nearly I have put nearly 140 150 questions in pleural effusion in my book. So everywhere in these areas they can be asking you the questions. Okay, then all the examination part I already said. Then in that percussion one, importantly they will ask, what is Garland's triangle, what is Gorokos triangle. Garland's triangle just above the pleural effusion, Gorokos triangle opposite paraspinal area. Please be thorough with Garland's Gorokos triangle, they can ask you in the exam. Clear? Right. Above the area of pleural effusion, what will be the percussion note called as Kodiak resonance. Okay, that is called as Kodiak resonance. Kodiak resonance. Okay, please be thorough. Suppose if the patient is having a right-sided pleural effusion, will liver dullness be elicited? It is difficult to elicit the liver dullness. Why? Because it will be continuous. The dullness of the pleural effusion will continue with the liver dullness, so we cannot differentiate. If the pleural effusion is in left side, what will be the trop space? Trop space will be obliterated. All these are questions, very important questions. Okay, once they ask the question to my senior, shifting dullness. You know what is the shifting dullness, right? Example, this is a bottle, okay? Dull. Now you are making like this and percussing. Now the dull has become resonant. Again you are conforming by bringing to the normal position. That is shifting dullness. They asked in pleural effusion, comment on the shifting dullness. So what did our person say? Shifting dullness is present. Then the examiner say, demonstrate. He did, it did not come. Then what the answer? Then he said, then my senior said, no sir, it will not come. So please understand the concept. In pleural effusion, there is no place for the fluid to shift freely, as in case of hydropneumothorax. This is classical hydropneumothorax. Fluid, air. Fluid, hydro. Okay? Air, pneumo. Hydropneumothorax. Here it will easily shift. But in pleural effusion, the space is very less to shift freely. That means what, sir? That means you are trying to say in case of pleural effusion, the shifting dullness will not be there. I am not saying that. I am saying in pleural effusion, shifting dullness will be there, but it will take long time to shift. That means the immediate shifting of pleural fluid will not be there. Whereas in hydropneumothorax, there will be immediate shifting of the fluid within 10 seconds to 20 seconds. Whereas in pleural effusion, shifting of fluid takes nearly about 20 minutes. Your long case itself is 40 minutes. In that you have to take from name, history, past history, personal history, everything, and you have to come till examination. You have to come till differential diagnosis. Out of the 40 minutes, 20 minutes you will spend only for shifting dullness. Remaining 20 minutes will you do all these things? So say to your examiner pleural effusion, shifting, there is no any immediate shifting of pleural fluid. This is what you have to answer in shifting dullness. So what does it mean? Immediately it is not shifting. That means it is pleural effusion. If immediately shifting is there, it is hydropneumothorax. Hope you understand. So these are the concepts breakthrough. Everything will be there in the book. Many facts will be there in the book. But such a concept breakthrough and developing and building a knowledge will not be there in a book which I am decoding to you. Understood? So after this, many questions is there. Like how will you investigate a case? What will you do? I will do a chest skiagram, that is chest x-ray. Then they will put a chest x-ray, they will ask you to explain. You have to explain, this is a digital chest x-ray, PA view, you have to explain all the points. Okay, well adequately exposed, there is no any rotation. Okay, soft tissue is normal, trachea is in the midline, there is an homogeneous soft tissue opacity in the right sided lower zones with blunting of the right costophrenic angle, most probably looking like an pleural effusion. This is the exact radiological description of that chest X-ray. So this all how to explain is there in my book. But you should have a practice of putting and explaining and explaining. Are you understanding? Then they will ask, if the X-ray, if the X-ray there is an effusion, okay, the blunting of CP angle, how much is the amount of fluid? Remember 5 points. Clinically, example, now my patient, I am able to see the decreased breath sound, correct? That means the amount of pleural effusion is 500 ml. Clinically, if you are finding positive findings for effusion, 500 ml is there inside. Whereas, if there is a CP angle, costophrenic angle blunting, that means how much? 200 ml. Okay. Then lateral decubitus, the X-ray view of choice. Okay, once in NEET exam they asked the question, what is the investigation of choice for diagnosing pleural effusion? All answered X-ray lateral decubitus view. Answer is wrong. Why? The investigation of choice for diagnosing pleural effusion is ultrasound thorax, USG thorax. Whereas the X-ray view of choice is lateral decubitus. Are you understanding? The X-ray view of choice. Because lateral decubitus can detect even 100 ml of fluid. Whereas ultrasound thorax can detect even 50 ml of fluid. Normal amount of fluid is only 5 to 15 ml. So normal amount 15 ml, ultrasound thorax 50 ml, lateral decubitus how much? 100 ml. Then chest X-ray PA view, blunting of CP angle 200 ml, clinically 500 ml. These values you should be thorough. Understood? So a lot of points like this will be keep on going. I am just decoding some important points. Then you have to know everything about tuberculous pleural effusion. What is that? How will be the ADA in the tuberculosis? How will be the LDH? Okay, glucose, proteins, how much will be the variations? Everything you must know. Similarly, they will be asking you about if it is a malignancy, they will be asking about malignant pleural effusion. How are you going to treat it? What is pleurodesis? Very important questions. What is pleurodesis? What is chemical pleurodesis? What is mechanical pleurodesis? Okay, when will you tap the fluid? How much amount of fluid you can tap in one setting? That is 1500 ml. If more amount of fluid you are tapping, what will happen? It will lead to re-EEP. That is re-expansion pulmonary edema. What is the treatment of choice for re-expansion pulmonary edema? IPPV, that is intensive positive pressure ventilation. Like this, the questions will be keep on going. Okay. I know it is very difficult to discuss pleural effusion in this 30 minutes, 40 minutes time. But I hope I had given an entire gist. Okay, lot of more questions are there, I agree, many more questions are there, but we cannot discuss all the questions in one setting. It comes, so only they are keeping in 2 months, 2 months they are giving posting for general medicine. In first year you are, in second year you are going, in third year one rotation you are going, in again in final year 2 months you are going, nearly 4 months you are in general medicine, right? So this 4 months is given for this only, to discuss all these things again and again, so that each and every time new points are being added. So all the points I cannot vomit out now. Okay, it is difficult for me also. So my friends and students, hope you enjoyed the class, hope you understood the concept of pleural effusions. So I know many more questions are there to go, okay, but please take this as a gist, as a motivation, and you please go further with these basic concepts. Okay, everything, answers and questions are available in my book. Once again I am saying, okay, and even a lot of pictures, lot of videos I am putting in my YouTube channel Sabrinath Ravichandar, my Instagram Dr Pulmonologist, my YouTube RS by RS, that is respiratory system by Ravichandar Sabrinath, that is my YouTube channel. Okay, I'm used to post all the awareness videos, X-rays, interesting CT scans, everything in my Insta, my Facebook and YouTube, so that you can understand different concepts, like how to read X-ray, how to take a dry powder inhaler, how to take an MDI, meter dose inhaler, what is the use of peak expiratory flow rate, different types of X-rays. So everything knowledge you can share from there also. Okay, so these are the different platforms, and my book is also there to help you. It is exclusive for clinical pulmonology. Okay, so I thank one and all for listening this video with humble patience. If I would have talked in an angry tone, or if I would have used some words, unparliamentary words, okay, kindly forgive me. My intention was not to use or to say something in a flow of speaking. Everybody has got a style. My style is like this, okay. I don't know whoever is watching this video, but it is never to hurt you or depress you, okay, or say something that I am very good, nothing like that. Just sharing of knowledge. You people also should get motivated and read, and you should become a good doctor. Okay, because everybody is going to do service for this mankind. Okay, so that is all my concept is. Okay, all the best, my dear students. Okay, so you can post any queries if you have in the Insta messenger. Okay, and take a leave. Okay, thank you.